This is 10 minutes now. You ought to rip this chapter out and give it to your radiologists. This is all the evidence designed to embarrass them about their ongoing demands that whenever you do a CAT scan that you give them oral contrast. Because their literature does not support this practice. But maybe they don't read very much, As Greg would say, you might have to slip this chapter between the pages of a Mercedes catalog, and they'll just step, while they're flipping, oh, geez, they might just fall on it. But in any case, many radiologists are demanding ongoing use of oral contrast for evaluation of appendicitis and evaluation of blunt trauma patients. How many of you are in that boat where you have to give this stuff? It is the majority. Holy smokes, the majority. Now you're talking about bringing this stuff over, this quart of stuff that this person has to drink, who may have a surgical abdomen. 2 quarts. That's in Michigan, Greg. That's a Michigan. 2 quarts that they're supposed to drink in somebody who may have a surgical condition where they're not supposed to be NPO. Somebody who may vomit and aspirate, those kinds of things, as you're trying to determine whether they have a surgical condition, whether it be a medical condition or whether it be a... Now, the list for reasons why radiologists think that they want oral contrast are listed there, like it may improve bowel visualization, to distinguish the small bowel from adjacent structures. It may improve visualization in patients with little retroperitoneal fat. Who are they? They're generally the kids. They say, well, maybe if you have a rupture in your bowel, you'll leak out this contrast and we'll be able to see that you have a bowel rupture. The fact of the matter is we're going to show quickly that very, very few people have injuries to the bowel or mesentery or pancreas, and that in fact CT is not a good study for those anyway, with or without contrast. You're going to miss a substantial number of those injuries, so that it's just not a good study, and it is not made any better by the addition of contrast in those cases. They say oral contrast helps detect fluid collections, pancreatic pseudocysts, and abscesses. So those are the pros. We all know the minuses. The minuses are risk of vomiting, risk of aspiration, transit time, how long are you going to wait before this stuff goes through. Studies have said it may take 4 to 8 hours. You may have some kind of ileus going on here where in fact this stuff isn't moving through the bowel we're talking about. And we're going to see study after study here where they leave this stuff in hardly any time at all and find out that they have poor visualization of the small bowel, oddly enough, because they only left it in 15, 30, 45 minutes, and some hospitals require an hour and a half minimum before they're willing to scan you after contrast. So it's going to take time. Some radiologists feel that the use of this contrast precludes the ability to assess the bowel wall itself. So the thing is, what if you have a situation where they talk about here like inflammatory bowel disease? You can't talk about anything regarding the thickness of the bowel wall, those kinds of things, once you feel the bowel lumen with contrast. So you can't talk about inflammatory bowel disease as a diagnosis. Abdominal angiography will be impossible after you give them any of this contrast. Undiluted contrast in kids is considered potentially a risk for them. It says here even potentially life-threatening. I have no idea why that would be, but they talk about artifacts that may be generated by contrast, which mimic or obscure diseases, and most studies say it's unnecessary. Not most studies. I haven't seen one study that says we did oral contrast and not oral contrast, and we've concluded that oral contrast is the way to go. All of these studies basically are generated by people saying, we don't think it's necessary, let's do a study. The fact is, it isn't necessary. And there's paper after paper after paper that your radiologists ought to see in terms of these outcomes, because if they believe that they can do a better job by putting an oral contrast in, it's a problem, because you're going to say, well, in my experience, once they say, in my experience, the science just left the building. So we have to here's 15 papers that say, please, the doctors don't want to use oral contrast in the clinical setting. Why don't you just try it without oral contrast here? And don't put this big caveat on, however, without the use of oral contrast, I really can't give you a good reading. Don't put that down. Thank you very much. So is it important to use oral contrast performing these things for appendicitis? First of all, we're irradiating lots and lots of people. The answer is no. The first paper is kids. Now, the kids are the ones who have the retroperitoneal fat absence. This is theoretically the ones who should get some benefit out of this. This is from San Diego, a study done on 112 kids, a diagnosis of appendicitis. They point out, yeah, there's a lot of kids where the diagnosis is difficult. They talk about a high perforation rates being reported. A lot of patients go to surgery and it turns out to be negative, so that's an issue. Some say this is one of the settings where this would be helpful. Like if you read the study, however, the children getting CT represented only 13% of the kids, 835 kids, only 13% got CAT scans, which I would say is surprisingly stingy. I think that that's probably where we ought to be. So they use this test very selectively. Selectively, it's the equivocal case. This is obvious appendicitis, we don't need it. This is not obvious, but you're well, you have no surgical signs, so we're only using it in this group here where we're not sure, we're using it in the equivocal cases. So they tended to, I think, based on the number of cases, they used it in those cases. What is the gold standard? The gold standard is, in many of these studies, is well, we used to do it with contrast, and here's our sensitivity and specificity with contrast. Now we're using it without contrast. What is the sensitivity and specificity? So they use historical controls rather than going forward using randomized control trial. This is the way it used to be. This is our results now. What are our results here? This study basically showed that the sensitivity for appendicitis without contrast was 87% and 94% specificity. I'll show you other studies that are better than that. But they concluded that this is the same kind of results that we used to get when we used oral contrast routinely in these kiddies. So we got no incremental benefit in these cases. But the more fundamental question about kids, we just talked about the radiation that you get when you scan a chest, scan these people. Why aren't these kids getting ultrasounds first? That's addressed by paper number 2 from Vanderbilt. This is a study of kids. 72 kids got CTs, 78 kids got ultrasounds. Ultrasounds, they did use pediatric radiologists. Look at their results. Both tests were very sensitive. 97% sensitivity for making the diagnosis of appendicitis with ultrasound, 100% with CT in this study of 70 and 80 kids. CT was a little bit better in terms of specificity. CT was a little bit faster, it took 5 minutes versus 20 minutes. The charges for CTs were higher than they were for ultrasounds. And CT was a little bit more better and beneficial in terms of picking up other diagnoses. But look at these numbers. These numbers are extraordinarily good. The question next is it an issue of the confidence of the reader of the x-ray, whether they feel more comfortable with contrast in or out? And they'd say, well, in my experience, I prefer it. I feel more confident in the diagnosis. That would be a problem. So that's addressed in number 3. This is where they looked at residents, and this is also another kid studies. They looked at resident and faculty radiologists reading these CTs. 91% agreements between the groups. The residents were not nearly as good, despite their. If you read the conclusion of the paper, they said residents and faculty were similar in terms of their ability. I went back to this original paper twice. 65% in the residents was their sensitivity. So they missed a good deal, a third of the cases. But the faculty radiologists missed 1 in 20. The sensitivity was 95%. And we're talking about hopefully equivocal cases. When they looked at their confidence, the radiologists in terms of the residents and the faculty, they were similarly confident. There was not a big difference in their confidence. So that's really not the issue here. The next paper, 300 consecutive cases, were referred from the emergency department. They used no oral contrast, no rectal contrast, no IV contrast. The sensitivity of CT in these cases, 300 consecutive cases, was 96% without contrast, no contrast. 96% sensitivity, specificity 97%, 99%. You're not going to get much better than that. The issue in all of these studies is, are they including all comers or are they including equivocal cases? 5 is a paper that focused on equivocal cases, 296 adults. Only 40% of them had surgery, clearly meaning they were equivocal cases. Unenhanced helical CT, sensitivity 96%, and only 40% of them got surgery. So they were clearly cases. The quote in this paper, thin section unenhanced helical CT is the optimal technique to detect acute appendicitis in adult patients. Some radiologists, I had a radiologist not too long ago who said, let's do it right, doctor. Let's take the time to do this study right. Let's give him the contrast. And there's a certain logic to that kind of thing. But the fact of the matter is this paper says the optimal technique is unenhanced. And I will show you some papers that suggest that use of contrast makes it more difficult in some cases. So this is not a question of more is better, because the other thing is these patients may wind up going to surgery and be subject to these risks. And the definitive answer is paper number 16. It's a 19-study review. 19-study review of this topic. Look at the sensitivities when they compared oral contrast versus no oral contrast. Sensitivities. The sensitivity with oral contrast was better than it was, the sensitivity without oral contrast was 95%. The sensitivity with oral contrast, 92%. Every one of these shows that there was a small advantage to not using contrast. So the conclusion of this paper, which is an analysis of 19 studies, says unenhanced CT appears to be at least comparable to scanning protocols requiring oral contrast. But look at those numbers. It's actually a little bit better. Will IV contrast add substantially to the yield of CT scans? This is a great paper. Number 7 is, what about IV contrast in these cases? This is a study where they used IV contrast after using it. They did the same patients. Here's what we're going to use no contrast, and then we're going to use IV contrast. So all these people got 2 CAT scans. They're all going to die in 30 years. And they'll never blame it on this study kind of thing. IV contrast enhancements after a negative unenhanced CT resulted in a diagnosis on the part of both radiologists in one case. So both radiologists said, yeah, I think I got something here that I didn't see on the plain one. They disagreed on what that diagnosis was, however. It wasn't any slam dunk. In another case, the unenhanced scan was felt by both study radiologists to be diagnostic, the unenhanced scan, but the contrast enhanced scan was non-diagnostic. The use of contrast made a diagnostic scan undiagnostic because it confused the issue. It made it worse. What are the studies indicating oral contrast is superior? I haven't seen any. I look through, personally, at least 600 journals a month. Personally, I've been doing it since August of 1977. I have not seen one paper that says, here's a paper, here, oral, IV, oral's better. Not one, not one. These are all saying oral contrast is not necessary. So it seems to me.
Is that just for appendicitis or for all abdominal problems?
Well, these focused on appendicitis, and if you think it's diverticulitis, it's a harder diagnosis to make, probably more reasonable to do, and even then you're not going to get any kind of contrast anywhere near the colon kind of thing. So those are places where they do rectal contrast, ultrasound. But I'm talking about the garden variety. We're looking about appendicitis and little Junior here. Does he need this or not? I would think, honestly, that this would extrapolate to many other kinds of things as well. Because we're talking about trying to find this little worm down there that's inflamed and a little swollen kind of thing. What about the setting of blunt trauma? Blunt trauma? We got bleeding in the abdomen. Do we have a ripped mesentery? Do we have a hollow viscous injury? Pancreas injury? Do we have any of those kinds of things? Paper after paper after paper says no oral contrast. 8 is a large and important study on this topic in which IV and oral contrast are routinely given. This is from, is this the one from UC Davis? Oral contrast was not considered essential. This is a study of a large number of cases. 2,100 scanned patients. Of 2,100 scanned patients, 22 of them had intestinal or mesenteric injuries, which is 1%. 1% of the cases. What percent of the 1% needed surgery? Hardly any. They say these are uncommon injuries, and all of these papers say occasionally we'll do really well with CAT scan without contrast, but we'll miss lots of these CAT scans, contrast, no contrast, because they compare many times their results. We always used oral contrast. We missed a lot of these mesenteric or pancreatic injuries, of which they counted on one hand. This paper had 6, I believe, pancreatic injuries out of 2,100 cases. They basically say, We used to use oral, we missed a lot. Now we don't use oral, we miss the same number. For those obscure injuries relating to mesenteric and bowel, contrast, no contrast doesn't make a difference. This is also the papers that say distribution of the contrast in the small bowel was adequate in only 60% of the cases. A quarter of the patients had vomiting in these cases. 20% had an NG tube put down to get the contrast down. You're making a big project out of this thing. And look at the conclusions, all of that is a waste and so subjects patients unnecessarily. The protocol required that they wait 90 to 100 minutes. In actuality, it took 2.5 hours more when they put the contrast in. This person's got a surgical condition cooking here maybe. They're waiting 2.5 hours to scan these people. Bowel injuries are uncommon in children. It's number 9. It did not reach the duodenum, 30 minutes in 60% of the cases. So a lot of these studies where they use contrast and they x-ray them CT them right after the contrast is given, it's kind of like, it's not a true comparison, contrast, no contrast, because they gave them the contrast so quickly that it didn't even have a chance to go anywhere. So it really was a study of no contrast, no contrast. CT is not reliable for diagnosing intestinal injuries, and it is not improved by contrast, is said by number 9 and multiple other papers. Number 10, just read the title. You don't have to read the paper. Oral contrast is not necessary in the evaluation of blunt trauma patients by CT. This paper, look at the date of this paper, 1993. This is not new news. This is a 13-year-old paper right in the title because these people are studying things that they think are controversial. So they want to present data that suggests that it's not controversial over and over. So this is an old paper. Give your radiologist this. Say, please, let's just try it, if you would, doctor. And number 10 is another paper that's common. How many of them had bowel or mesenteric injuries? 1% of 1,082 cases had bowel or mesenteric injuries. CT without contrast identified 9. And was falsely positive in 5. Again, not very accurate no matter what you use. We could do paper after paper after paper here, and I don't think we need to go through these. Well, the last one talks about what's the radiation consequences of radiating somebody's little belly here. This paper says physicians are inadequately sensitive to the effects of radiation and that many, many diagnostic radiologic studies are not worth the benefit of radiation versus outcome in terms of changing your practice. This paper quoted another paper, which I believe that said something to the effect that 30% of radiologic imaging, the radiation dose was disproportionately high to the yield that was going to be coming from those people. So 16 puts the radiation dose together here. These are all kind of mathematically tough articles. They make a lot of assumptions. Some of the assumptions could be challenged. They all acknowledge that the risk is greatest in children. We had one kid at our hospital that had 3 CAT scans in the evaluation of appendicitis. 3 CAT scans. This kid was 7 years old. Even the technologist who did the study said, "What are you guys doing?" But this has already happened. And he just caught me in the hall because he knows that I'm a little interested in this stuff. So they basically talk about an ethical responsibility to convey these risks to patients. We take the impression many times, don't tell them about it, it's don't say a word, understatement of the risk, there's no problem kind of thing. They suggest that there are some risks associated with these tests, and they make the assertion here, 30% of tests involving ionized radiation are inappropriate, with patients accepting a long-term risk without commensurate acute benefit. So they talk about, and there's a little chart here, I believe. Yeah, there's a chart there in the book that talks about the risks of you dying. Thallium scans at the top of the list. See that? Thallium scans high. In trying to make informed decisions about who ought to get what, because there is something coming out of that machine. They talk about the risk of a belly CT. It's 500 chest X-rays, 1 in 2,000 deaths. It's very similar to the number we had for the CT of the chest for the pulmonary angiogram studies. So they suggest that there are some issues regarding ethical obligations to communicate, and that anybody who's getting a procedure associated with a high radiation dose should, they think, be mandatorily told of it. Communication of a dose should be mandatory for high imaging techniques, thallium scan being at the top of the list. every patient that gets a thallium scan should be. Now, I don't know whether you agree with that or not. This person maybe is kind of like overly sensitive to this stuff, but when you think about 1 in 2,000 or 1 in 4,000 people dying 10 or 30 years later after you did this study, which they probably didn't need in the first place because the diagnosis, the surgeons now call them down and say, what's the CAT scan show? Before they even examine the patients. That's not right. That's not right. All right.